Hey, it's Justin Harvey. Thanks for tuning into the Anesthesia and Pain Management Success podcast. With APM Success, we take a close look at important topics pertaining to business, practice management, personal finance, and careers for anesthesiologists and pain management physicians. We work hard to take your critical questions straight to the experts. Thanks for listening. Hello and welcome to another episode of Anesthesia and Pain Management Success. I'm very pleased to be joined by Dr. Jay Grider. Dr. Grider hails from Kentucky. He is an interventional pain physician, but he's also one of those physicians that has an unusual grasp of all of the different stakeholders, many of the different policy implications, downstream effects of all kinds of things. He is an immense wealth of knowledge. He also has the rare distinction of being the first interviewee on the Anesthesia and Pain Management Success podcast. So if anybody wants a chuckle, you can go back 266 episodes deep into the archives. This show has come a long way since then. Dr. Grider, thanks for being here.
Hey, the show may have come a long way. I'm not sure that I have. So probably hear the same jokes again. So there you go.
Oh, I'm counting on it. So I had reached out to you the other day and we were brainstorming a little bit about topics. Why don't you talk a little bit right now about sort of your current scope of responsibilities? And then let's dive into the work you've been doing with Medicaid and impact on state health systems and how that interacts with pain management in particular.
Sure. So I serve in a system role for quality and safety, and I also oversee the physician practice billing arm, which is the foundation, Kentucky Medical Services Foundation. And within that, I spend some of my time working with our legislative affairs team on the impact of different policy decisions and how they are affecting healthcare, and we just live in very uncertain times. So also within that, we'll be and have been to some extent working on, but in the future we'll be working with our external partners here at UK and how we care for the state, as it were, through any health properties that we acquire, that we management partner with, or that we have partnerships that are independent, but that we work with through contractual obligations to try to help. So a little bit of a varied existence there. So happy to go into anything you want to talk about.
What does a typical day in your life look like right now?
So still active clinically. There's just so much new that's coming into the interventional pain space that's exciting, from lateral SI joint fusion, posterior lateral SI joint fusion, to basivertebral nerve ablation, to intradiscal therapies, to to posterior lateral percutaneous arthrodesis, which would be, fixation, in addition to the normal things like spinal cord stimulation, and then the whole area of regenerative medicine and peripheral nerve stimulation. It's really just exploded in the past 5 years as to things that you can offer clinically. So there's a lot more things that have efficacy that you can apply. So, couple 3 half days a week, I'm doing that, and then usually a day every other week in the operating room, implanting or doing one of those types of procedures, and then spending time thinking about how we improve quality, value, and safety for the citizens of Kentucky that are seen not only at UK Healthcare but across our region. So a day can be pretty varied, from having a discussion about why our CLABSI rates are high, to trying to talk about why our physician reimbursement is declining, to talking to someone because they're frustrated because their radiofrequency ablation didn't work on their lumbar spine. So it's a varied day.
Cool. I want to come back to the sort of procedural developments of pain management, and I think a few different specialties.
Sure.
But let's start with the policy, the reimbursement, the sort of payer negotiation considerations when you're in a room with your fellow collaborators and you're examining these system-wide, statewide problems and challenges. What are the couple issues that rise to the fore as things you're trying to address that you think will have the biggest impact?
Well, so you take a state like Kentucky, and let's go back to 2008, whenever you have the Affordable Care Act that comes on site. So you rewind back to that and you think about what the problems were at the time. Well, you had employer mandated insurance, which required that you be employed in order to to have health insurance. And so the reasons why we tied insurance to employment date all the way back to World War II and have been covered by numerous people. But there were wage freezes, and so you couldn't offer people more wages. But one of the things you could offer was health insurance, and so we got into this tradition in the United States, intra-war and post-war, of tying health insurance to employment. So it's a little bit of an odd system. Not a lot of places in the world have that. I'm not an expert on insuring and reimbursement about healthcare in every place, but that's the history of us. So you go into that, and then you couple that with some changes that happened in the 60s. I would say, and having watched my father practice, physicians were middle class individuals, in the 40s, 50s, and 60s, and they fought bitterly the institution of government intervention in healthcare. And they thought that Medicare and Medicaid were going to be the end of healthcare as we knew it. And actually, nothing could be further from the truth. The transition of physician incomes from middle class incomes to something beyond middle class was actually through the government payer system. So and used to get paid in this country in what was called a usual and customary charge. So if I took a gallbladder out and I wanted to charge $350 for it, I'd bill the government would pay it. And eventually they said, hey, people are figuring out that if they charged $400, we'd still pay it. And if we charged $425, they'd still pay it. So they created a system in the 80s and early 90s that was the RBS system, which tried to create some degree of customization of unification of price. That didn't work. None of the controls that we've done have really worked. And so with the expansion of Medicaid, as it became more and more expensive for employers to meet the healthcare cost of their obligations in order to attract employees, at one point, I think, GM's largest expenditure was on healthcare. The cost of making cars was less than the cost of providing healthcare. So in essence, GM was a healthcare company that just happened to make cars. And so being able to offload the cost of healthcare especially of small businesses, was an aim of the Affordable Care Act. So I'm not here to debate the right or the left of the Affordable Care Act. As one of my mentors said, I didn't invent gravity. I'm just explaining it to you. So don't be mad at me. So what happened in Kentucky and what happened in 5 other states that did vast Medicare expansion was we took 1.3 million uninsured Kentuckians and put them on rolls. So it's probably unfair to say that 1.3 million of them were uninsured. 850,000 of them were uninsured. Another 500,000 or so had insurance of some kind, but transitioned to that. And so Medicaid, at least in the Medicaid expansion states, shifted from being disabled and lower income to being a lot of our middle class individuals were on Medicaid. A lot of the working class was on Medicaid. And so that was a good thing, because access to care in our state went through the roof. Bad debt dropped to almost nothing. With that came the realization that we needed to have better outcomes for patients. And so in our state, we tacked onto the Medicare or Medicaid expansion a quality incentive program. And if you met certain quality incentives, there was a supplementation of the Medicaid rate. Used to be Medicaid was paid to hospitals just in a block grant called DISH, disproportionate share. But through this program, hospitals and physician practices could participate in a government program. And if you improved quality, your rates were better, and it actually became a reasonable payer. So at one point, Medicare became our worst payer. Medicaid became a middle of the road payer, and then obviously there's commercial payment. And so that stabilized the health system in a state like Kentucky and in multiple states across the country, because health systems were getting pressurized in some pretty significant ways. But as we have started to look at all of the things that happen, these programs are coming under scrutiny, which is a little bit ironic because this is a very red state. The state is very, very, very right-leaning. Yet most of the people that are getting health care in this state would be getting it because of the price breaks that happen through this program. Now, the costs have escalated, but that's because it's a government program. Every government program has cost escalation. So education has cost escalations in healthcare. So we do have this outstripping of cost for the outcomes that we get, and we know that in this country. So the discussion is the right discussion to have, which is, how do we get the right amount of healthcare expenditure for the right amount of outcome? But we are not societally at all ready to have the true honest discussion that we need to have about the proportions about how things cost. It is a bit of a misnomer. You talk about one of the first things that comes in is anytime that there's cost savings, people want to talk about reducing payments to physicians whenever physician payments are 9% of total healthcare expenditures. They are not the cost overrun. But then you look at health systems. As a health system leader and a hospital executive, I also see that most of the hospitals around are turning dollars right back around and reinvesting them in people to do the work, because we have shortages of people, or facilities to see more people. There are very few situations in this country where there is not reinvestment right back into the bottom line around healthcare. There are some things that could be done differently. Like, I think whenever the CEO of a healthcare organization makes 37 times the average work, I think that's a problem. I saw something that came out in Becker's Healthcare 3 years ago, and I made a slide out of it. Simultaneously, if anybody's read Becker's, there's 2 lines. You'll have 10 lines of things, and it's just blurbs. And the top line was, Kaiser Permanente loses $3.2 billion. And the next line was, United Healthcare has record profits. And so you open this up, and Kaiser Permanente, which is thought to be by far the most frugal, they're a health system that owns soup to nuts, the insurance product, the physicians, the hospitals. If costs can be controlled, Kaiser Permanente is going to do it, right? They're famous for it. They had lost $3.2 billion, of which 1.6 was in investment. So give them a break, but they'd lost $2 billion on operations. Meanwhile, United Healthcare had made $760 million in a quarter, which would be a $2.4 billion profit. And I made this slide and I tweeted it out. And I put in that slide, nobody ever purchased health insurance with the hope of increasing shareholder value. Meaning, you bought it for your mom or your dad or your kid or your wife. You didn't do it so that shareholders at United Healthcare could distribute dividends. And I tweeted that out, and it got picked up by Dr. Glaucomflecken, and it kind of started to spin out of control. And our media people said, hey, we love you. We love your sense of humor, but if you could just not do that, that would be really helpful to us. If you could not make our job 5 times harder, if you just make it twice as hard, we'd really appreciate that. So I don't go on social media anymore. But so that's kind of the environment that we're in. So right now we're in this uncertainty, Justin, where there's a pocket of our political nature that would want to walk back Medicaid, but that's really a complex unraveling.
Yeah.
There's a pocket of our politics that would say we should expand all government payer. I'm not sure that's a great solution. The idea that entrepreneurial business is the solution, entrepreneurial business will make anything that's profitable quite profitable and quite efficient. But those things that are difficult or chronic or ugly won't get touched by the profit motive. And so the very poor, the disabled, the person who needs a transplant, how do you provide care for that situation if there's no entrepreneurial way to stimulate that? And so that's the place that we are. There's a lot of narratives that take one of the most complex issues and tries to boil it down into sound bites that don't apply. So navigating that is quite difficult. And to be honest, there's a lot of moving parts. Not sure where the shoe drops, but what I will guarantee you is that there will be a decoupling and an unraveling that has to happen. Healthcare is a bubble, and everyone who's living in the middle of a bubble lives and exists in it, knowing that they're living in this artificial reality. And when it pops and bursts, it's going to be difficult to see where that goes. But there is no doubt that it is a bubble, and how it unravels is going to be fascinating. And I think we're witnessing it happening right now. So, boy, that's a speech, isn't it? I'm done. What do you have a question?
I two questions. The first is, what memories do you have of your dad as a physician, who I didn't know he was a doctor? How did he practice, and what was his interaction like with the medical ecosystem at large, and how does it differ from what you observe today?
So the primary care physician in our town, Dr. Adams, I remember as a small child going to see him, and he would literally say, you'd go see him, and I remember my mom saying, "How much do I owe you, Dr. Adams?" And he would say, "Oh, that'll be $1. That'll be $2." Now, this was 1974. It wasn't like, 1830. He was charging $1, $1.50, $2, $3. My father was charging $10 to be seen in an office visit. And so, I remember whenever he died and I was cleaning out his office, looking at his biochemistry textbook, and it had a section on proteins, a section on carbohydrates, and a section on lipids. And it dawned on me that DNA hadn't been discovered yet. And I thought, what is it like to practice healthcare in an environment where like you saw the discovery of DNA happen? And that gives you some perspective on what was it like to practice,
Probably had a price sticker on the inside cover. It said $3.99 or something.
Yeah,
like
so
that
something of that nature. Yeah.
So in terms of how Medicaid has evolved in your state and the way that doctors interact with it, so one of the things I obviously work with a lot of doctors. I see sort of the guts of their practices, those who are independent practitioners, and thinking about payer mix, thinking about reimbursement, thinking about how do we make it work, thinking about quantifying everything that can be quantified, and in the good old entrepreneurial fashion, like we got to understand. And obviously, there's sort of the governor of the the Hippocratic Oath, but there's also their awareness that, like, if we're going to make this thing work, there's no mission without the profit that is going to keep your business running. So how do you see doctors interacting with Medicaid and with the incentive programs, and what is it like for physicians in your state?
So, I was talking to a physician leader of a large multi-specialty group here locally, and I said to him, I said, whenever all the dust settles, the only people that are not nervous right now are you all. And he said, we're not, but why do you say that? And I said, well, because you've always limited your exposure to Medicaid. And I said, yet you have a reputation as being this deeply caring multi-specialty physician group. I said, do you find yourself at odds with that? And this is a deeply spiritual person, very, very, very very conscientious in the way that he speaks and very kind and compassionate. And he said, yeah, he said, it's not that we don't want to see people. He said, it's just the fiscal reality that if we are losing 50 cents on every widget that we create, creating more widgets is not the answer. He said, we just can't keep the lights on. And he said, it's not that we don't want to. He said, we would love to see everyone regardless of payer, but we live in an environment where we have to think about payer mix. And so that shifts certain payers to other institutions. Mm-hmm. And he said, you all have a situation where that works for you. And so he is correct. We have a system where we can take care of the person regardless of payer mix. And our cost of care is very expensive because the overhead for a heart transplant is built into my epidural steroid injection. So whenever I run the financials in a pain clinic and I do it based off of our staffing and our cost and expense, we do pretty well. And then we pile the overhead that it takes to have ICU nursing standing by ready to do a heart transplant. All of a sudden, the realities of the complex health system come into play. And those dollars are absolutely needed in order to provide care on a moment's notice. It's expensive to have a trauma surgeon standing by, ready to take care of you, but you're grateful whenever your 5-passenger van has run into a semi-truck on the interstate. So these are very complex things. Yeah. The payer mix issue is key, but how do we figure out a real system where the individual practitioner, the primary care practitioner, the independent orthopedic practice, the local hospital, and the academic medical center can all meet the missions that we need them to meet, and that we can provide the expectation of the American public, which is you will give me access in a moment's notice to the highest level of medical care in the world. And so we're having a conversation here, not only as we talk about the finances, how do we put the patient in the center? What does the patient want? They want expeditious care, they want compassionate care, and they want it to be high quality, and that would be safe and evidence-based. And safe and evidence-based are not the same thing. I can be safe but not evidence-based. I can be evidence-based but not safe. So quality is both things together. And then what do the people we hire need? They want to be seen. So whenever we will recognize you as a worker, whenever you provide efficacious, expeditious. So when you get somebody into the healthcare system quicker or move them through quicker, we're going to brag on you for that. It'll be compassionate and it will be safe and evidence-based. And so then we need to compensate you for that. So those are the things that we're asking is, how do we do all of that in the midst of nursing shortages, in the midst of provider shortages, with demand out the door and down the street, providing patient satisfaction? It takes 8 months to get into our neurology practice. That's about average for some subspecialties in academic medicine. What do you do in those situations? Whew.
As you think about those handful of things that you articulated for your physician employees that you want to, the quality metrics, whatever they look like, and also maybe even more broad than, maybe this falls under quality for you, but like the efficiency, throughput, the various ways that we can quantify the efforts of a physician. Can you talk about some of the ways that you have tried to think through the right metrics, develop those metrics, measure them, find better ways to measure them, and then reward on them, communicate around them, that whole process?
Yeah, so I think you have to have an understanding of what I group physicians into certain categories. So there are some specialties that do work pretty well on a productivity and efficiency model. Orthopedics tends to work, most musculoskeletal things seem to work okay on a production model. There are a few doctors that you have to slow them down and say, hey, you need to think about quality. And so having a little bit of a quality focus, but most musculoskeletal physicians put them into some sort of a productivity, make them efficient, give them lots of ability to drive volume, and they will take care of a large number of people in a very safe, efficient manner. But that system does not work at all for your primary care doctor or for your rheumatologist or for your endocrinology doctor. So you need a solution shop there that allows people to slow down, spend some time, think about things. I work in pain, so I need to work at two speeds simultaneously. I need to be able to do things that can be done quickly, and I need to be able to slow down for the patient here and there who really needs a slower, focused approach. So I need something a little different. I need to be able to run at 1,000 miles an hour and then go, I got to spend 45 minutes with this one person and help figure out what's going on with this situation. So I think each individual practitioner needs to think that through. The volume and the productivity that I can generate over here allows me to slow down as long as I don't get too far behind and spend time with this particular weird case that doesn't fit easily into that model. But there are people that all they see all day long are complex, time-consuming things. How do I make sure that whenever my cancer comes or whenever my chronic metabolic illness comes, that somebody will sit and take the time with me that I need to figure out what's happening? So I think you've got to think about how to fix things. Fortunately, Justin, you're talking into a space that is full of entrepreneurial, efficiency-minded people that are able to do what they need to do. They're able to drive incomes for themselves that are good, and the outcomes for their patients are good, because really what the patient needs is access to this well-oiled machine. We have an orthopedic surgeon in town who can do 10 total joints in a day. That's crazy. That's insane. He's great at it, and his outcomes are fantastic. If the government said, we're going to pay you the same amount of dollars regardless of whether you do 10 in a day or you do 2 in a day, how many would he do? This individual probably would do a few more because he's just that driven, but I think you have to be cautious about, you do get what you incentivize in every case. So having a quality metric at the end of production is one thing. Having a solution shop where you can slow down and reward people for thinking is really key. We've never gotten that balance correct. Health systems have to do it on the fly because we have to have endocrinologists and we have to have, sports medicine doctors, and they think very differently. So,
and the incentive so often drives the focus and the motivation. And the example you gave, which is a good one, is I'm going 1,000 miles an hour in the morning in clinic with my 2-inch putt for birdies, and then I got the person who comes in after lunch, and it's the multifactorial, very complicated thing, and it's 45 minutes if it's a minute, in order to give them the care that they need. What are some of the brainstorming sessions, assuming we'll just use pain management as an example, which is I think the RVU system kind of works reasonably well for that based on the description you just gave. Have you come up with any ideas for how do we incentivize, if this doc is getting paid on RVUs and they spend 45 minutes talking to Mrs. Jones about 6 different things, how do we incentivize the physician to give her the 45 minutes rather than kicking her across town to somewhere else that's less quantifying of these metrics, and maybe it's just going to spend more time just because they don't know how much it costs?
Yeah. There really is no way in the current makeup. Because even if you said, okay, I'm going to do a level 5 new patient office visit here, you scheduled yourself in such a way you didn't know that this was going to be, a conversation that you could measure with an hourglass. So it's really impossible to figure those things out. I think most practitioners just have to figure out that balance on their own in the current setup. So,
another thing that I've read, and I'm curious how you've interacted with this as you think at the system level and sort of the population level, is the amount of expense that's incurred in the last, I don't know what the number is, 6 months, year of life, and I'm trying to remember which book it is, where they talk about the conveyor belt and like you kind of get on the conveyor belt, and then you're sort of going through the end of life care that is very interventional, very expensive. Throw everything at the wall and see what sticks. You have ill-informed family members who, even if you try to tell them, like Dad said, do everything. He's a fighter. Like give Dad everything, and it results in an outsized percentage in terms of like what we're paying for. Have you interacted with that at all, and how do you think about that challenge?
Yeah. So, you know, in our own system, there is um, a genetic cancer drug that is very expensive. It's $25,000 a dose. And one of our oncologists asked to use it not long ago. And and I'd been on call to answer those questions and I said, okay, if you think that this will be helpful, do it. And they administered the dose, and the person died of their disease, not because of a drug complication, died of their disease about 18 hours later. So in reality, they were palliative when he called me. And I called this guy back and I said, it's not about the money, although it's considerable. The question is, why did you feel that it was necessary to utilize resources whenever clearly somebody's medical need was more palliative than it was anything else? And, the answer is, well, I've been trained to do until the end. I've not been trained to think holistically. Some of the cardiac surgeries that are done, whenever you look at the expected mortality on them, after a 3-time redo, this would be the third time you're entering the chest. The survivability on some of these things is really, really low. And what's the cost on that? So yes, it's not about not spending the money. We're spending the money now. The question is, would you want your loved one to be tied up to a ventilator on an ECMO machine with 3 drips, or would you rather be in a peaceful, comfortable setting, saying goodbye with some degree of dignity? And I think most people, if they knew the true likelihood of the outcome, would choose something very different. But these are conversations that we as Americans are not quite ready to have yet. So anyway.
It can be, I'm sure, difficult, and it probably feels thankless to have to tackle a problem with so many stakeholders, so many variables. It takes so much political will to do something for long enough to see if it's even going to work, and all the harassment you have to take in the meantime. Are there any bright spots or moments of encouragement you've seen in this work that you're doing where you thought, you know what, this seems to be paying off?
This is everyone. This is Justin saying, "Boy, the anesthesia podcast has gotten a little heavy today. How do we pull the nose of the plane up from Dr. Kevorkian here?" I mean, remember that movie, The Sixth Sense, with the kid who saw dead people and they didn't know they were dead?
Mm-hmm.
I think I have a sixth sense. All day long, I walk around our health system and I see confused people. They just don't know they're confused. So my job is me and other people. It's not just me, but my job is to help them be less confused, to help them see the bigger picture. And on occasion, you get an aha moment or yeah. And so, yeah, no, there are bright spots. So the Medicaid value-based care program that we run here at UK. So we went from well child visits, which if you're running 48% well child visits, you're doing well, and driving that up to 90%. Okay, you ask pediatricians, are well child visits important to help in the first few months and years of life? They say, yeah, it's very important. Okay, so these are all bright spots. Diabetes control, blood pressure control. These programs do have outcomes, and they are changing the outcomes for Kentuckians. So yeah, there are huge bright spots all over the place. The problems are myriad, and the successes are hidden and one-off and are very individual. And you do have to remind people of those successes. So absolutely, it's just it's easier to tell the stories about things that must change because they're frustrating than it is to when you go to Chick-fil-A, you expect to walk out with great chicken, a good drink, a my pleasure, and have it done quickly. You complain about Chick-fil-A whenever they didn't put the Chick-fil-A sauce in, or you ordered strips and you got nuggets. That's when you complain about Chick-fil-A. So, yeah. Or to quote somebody, no one ever applauds the tenor for clearing their throat. So anyway.
Let's, in the time we have remaining, talk about some of the new therapies in the
Sure.
specialty and some of the, sort of interspecialty conversations that's starting. And as there are more tools in the toolbox for pain management doctors, and they're talking about taking the fellowship to 2 years, and there's so much training and so much of that is led by industry too. I'm curious how you interact with, like, how do we get our pain fellows up to speed? How do we think about, like, sending them to the workshops sponsored by XYZ Incorporated versus in-housing some of that? And that sort of, there's so much, it's happening so fast, and such specialization is needed. It takes a while to have the infrastructure to
Sure.
get docs proficient.
Yeah.
So how do you engage with those challenges?
Sure. So, very excited about the work around, we're thinking about the spine now in terms of the functional spinal unit as having the posterior column, which are all the facet denervation things and, all the things that we've done, the central column, which is all the things that get spinal cord stimulation and intrathecal drug delivery. Well, we've beaten the posterior column and to some degree the middle column to death, and the anterior column, which is a huge pain generator, there's not been much for. And so things like basivertebral nerve ablation and intradiscal therapies are starting to emerge. And what we're finding is there is just a plethora of patients with this problem. And the outcomes for this stuff are very durable and they're very encouraging. That when you couple that with sacroiliac joint stabilization, I think those are the two big things that are coming down the pike. So very indebted to Tim Deere, Dawood Syed, and Aspen for having the vision to talk about regenerative medicine and the vision to talk about intradiscal therapy. And so there's a publication that we're working on that's going to try to educate the space. Just like whenever mild came out 15 years ago, spinal stenosis was like, believe it or not, radiology had not defined what spinal stenosis was. It was the interventional pain physicians with this new tool that they had in their hands that needed to quantify what's really truly moderate stenosis versus severe stenosis. And the interventional pain physicians defined these things because of the focus on the ligamentum flavum. Same thing is happening in the interdiscal space. We're having the discussion around, how do we educate the entire space around disc degeneration, disc classification, around techniques and treatments. And so very excited about that. I think that's going to explode the number of things that we have available to us to do. And a lot of pounding the square peg into the round hole of I have a bunch of posterior column innervation or techniques, and let's try that and see if it works, even though I think it's not really, doesn't really fit into that box. Well, I think we could truly try to start to treat the area that's helpful. As a result of what you talked about, pain fellows are now, there was a lot before. And so you came from anesthesia, where if you came from anesthesia, a physical exam was, stick your tongue out and how big is your chin. And if you came from PM&R, you understood physical exam, but sterile technique was, let me wipe that off with some alcohol and see how we do. So you've got all of these different disparate things you've got to learn in a year. Mm-hmm. It is truly drinking from a fire hose. And then you want to try to get all the injective procedures, neuromodulation, and now all of these bigger interventions. It's tough. And the crazy thing about it is I was telling our fellows the other day, with what I'm doing now between lateral fusion, with kyphoplasty, with intradiscal therapy, with Minuteman, add mild in, I am doing 55% of things that I never saw or dreamed of as a fellow. So you've got to be ready, or you will be practicing 2025 medicine in 2050 if you don't have the courage to expand your skill set. And man, just keeping up is hard to do at this point. So it is volumetric, but it is a really exciting time to be in the field.
What impact have you seen with sort of the anesthesia shortage and a lot? What I've observed, anesthesiologists like doing a lot less fellowships. I know some pain fellowships have struggled to fill their role, and there's also been other specialties that I think are feeding into pain management. What have you observed in that department?
Yeah, absolutely. So as anesthesiologists have decided to go work in the operating room, which is a fine thing to choose to do, we are many programs that were quite frankly discriminating against non-anesthesia graduates are having to either reduce their volume of folks. We've been pretty open in who we've taken for a long time, and I find that the specialty is better for it. I think a lot of the advances that are happening are because of the influence of physical medicine and rehabilitation. Um, in the adoption of forcing the center to move towards other things, I think we would be a spinal focus, the appendicular skeletal stuff that physical medicine rehabilitation is driving. It's going to be hard to either be, I think people are going to have to choose to be a spinal interventionalist, or am I going to be a regenerative interventionalist? It's tough to do both because they're both evolving so rapidly. So I don't see a problem with it. I think that it was too restrictive and too exclusive in one direction before. Don Corleone said we always get rich on what our enemies leave behind. Well, if anesthesia is going to leave the specialty behind, it will evolve to the place that it needs to be. Nothing ever happens, everything happens for the best. And I think that the evolution of this specialty into something that is less anesthesia focused is key. Let me give you an example of why that is. I was talking to one of my anesthesia fellows, and I had a PM&R fellow with me. They're both right there. And just the idea as an anesthesiologist, like other physicians will say things like, "I'm sorry, I don't think I have anything to offer you." But as an anesthesiologist, we are never trained that way. We will always anesthetize you. So we will always come up with one more block to do, one more procedure to do, one more thing, even if it's kind of harebrained. Whereas the other specialties bring I think we should stop. It might start to get dangerous to this. And so just the way you're trained as an anesthesiologist brings a certain, damn the torpedoes, full steam ahead, got to figure it out. Because at no point in your training did you ever go, "I don't think we should anesthetize you." You might say, I think it might not be safe. We might do it under regional, but you were going to come up with something. Whereas other physicians are okay to say, "I'm not sure there's anything for this. I think we need to take a more cautious approach." So yeah, I think the specialty will be better off, even if it doesn't feel like it will be.
For the as you sort of think about your peer group, and particularly like maybe those who have been out of training 3 or 5 years, who seem clinically like they've got the reps in on their highest volume procedures, and they're pursuing clinical development on a track that allows them to continue to give like the safest, highest quality treatment, and in the midst of like this multiplication of various therapies. Think about doctors who that seem to be navigating that well, like wanting to get enough reps to execute something well, and also get enough exposure to the breadth of things available to be able to offer newer things to patients. What characterizes, in your observation, the doctors who seem to be dealing with all that, the tumult of all those options and treatment pathways and different things, that they seem to be doing okay, hanging on and developing well professionally in the midst of that?
So I did a study whenever I was doing a lot of regional anesthesia, and it was whenever ultrasound was first coming out. And so there were anesthesiologists that would do regional anesthetic blocks blind, and there were anesthesiologists who would use a nerve stimulator, and there were anesthesiologists who would use ultrasound. And I wanted to see which of the three were better. This was a study that we did a long time ago. So, and within that, I surveyed the people who were doing the procedures, and I surveyed the outcomes. And so residents and attendings would all say that they thought a blind injection was as good as an ultrasound-guided injection. In other words, they thought that their blind palpation skills were as good as using ultrasound for certain techniques. But then whenever you ask them the question, if you knew that this block had to work for surgery and it was the only anesthetic, no one chose a blind technique and everyone chose an ultrasound-guided technique. So what I'm getting at is this. When you teach yourself a procedure and you don't have any feedback on it, other than you went to the course and you've done the best you can, you think that you're really good at it after you've done a few of them. But you go to watch somebody who has more skill in it, and you will quickly learn that there are things that you're unaware of that would really improve your ability to do it. And so I think the problem is that we don't have these sort of clearinghouses where people can come in an easy place and come spend a week with somebody who's doing something more frequently. So learning it, most people are learning things in a weekend and applying them on Monday. And you can get up to some degree of proficiency, but to get to that place where you're expert at it, where you have really eliminated a lot of the bugs, I think that's where the mediocrity in the profession hangs. And it's going to be difficult to figure out how to ensure that quality measure is there. I will assure you that a weekend course isn't what you need. And if we think that having an experienced non-medical rep in the room walking our physicians through how to do procedures is great, let me get you to think again.
So if I'm that, and we can wrap it up here, if I'm that doctor who's like, you use the word mediocrity and I don't want that to be in any way associated with my clinical expertise, what do you recommend for those fellows or newer attendings who want to develop in these ways?
Well, so I'm not using that term as derogatory towards them. So as I learn a technique, I pass through a mediocrity stage. Now, my goal is to be on the leading edge of innovator to early adopter. So everyone who's an innovator or an early adopter is going through that same thing to a degree. So that's how advancements are made. But how do you take the early adopter and the late adopter and get them, to a degree of proficiency quickly? So you've learned and you've made the mistakes. Then how do you benefit the middle of the bell-shaped curve? That's really what I'm talking about. So I go through that with every new procedure myself. So it's not a criticism. We all have to go through it. Everyone stinks at some point. It's how do we get the stink off of us quickly onto proficiency and safely. So that's really what I'm talking about. But you have to just hold your nose and be willing to go through that return to novicehood that you resist. That's why it's so easy just to stay with what you know and the bread and butter that you do. So,
yeah. And for anybody who doesn't believe Dr. Grider, rewind to episode 2 of Anesthesia and Pain Management Success, which was at that time called Anesthesia Success. And then you can listen to this one, and hopefully there's a little bit of a difference in what you observe. Dr. Grider, thank you. It was a pleasure speaking with you. Appreciate you lending your expertise to the APM Success community.
Appreciate it. Thank you.
If you liked what you heard this week, head on over to apmsuccess.com, where you can find more content and free resources to help you build a successful career in anesthesia and pain management. If you wanted to leave a review in iTunes, I'd also really appreciate it. Thanks for using some of your valuable time to join me today on APM Success.